Thank you very much, David. I think, simply put, I'm just a neurointensivist working in Toronto and a clinician scientist doing a lot of work in acute brain injury. And so I'm really excited to be talking to you today in this session about technology in ICU. And thanks for the organizers for inviting me to talk on all my talks. And today we're going to talk about improving the care of acute brain injury with data. I have no disclosures for this talk. And so big data has been seen as the new gold. Maybe a bit of an overemphasis, but we're definitely in the fourth industrial revolution. And it's maybe not so much about the new types of data. I think the value is really in the way that we're able to accumulate and the availability of the data. So a lot of our paper records are becoming digitalized, and it's the way that we're able to aggregate, synthesize, and analyze all this data that is most likely providing a lot of the new insights that we're seeing, especially in traumatic brain injury. And I may posit that maybe a bit topical, but to say perhaps data is helping with our outcomes as opposed to drugs. There has been this hunt for the magic bullet for a neuroprotective agent for the past 20 to 30 years in brain injury. And although all these studies and very early animal studies have been very promising in the preclinical work, in phase 2 and 3 studies, we have seen that unfortunately they haven't shown any improvement in outcome. But that being said, we've had amassed this huge amount of data through all these studies. And one example might be the Symposium trial, where by even looking at that, we've been able to understand that acute brain injury process. And we can understand through a lot of that data from these neuroprotective agent studies how these patients evolve dynamically over the first week and continue to deteriorate neurologically. And a lot of their work is always the slide that you put up to show how people are going to deteriorate once they get admitted to your ICU with brain injury. And so despite these failures in neuroprotective agents, the outcomes for at least traumatic brain injury and possibly all of our neurocritical care patients has been improving over time. And I would say that a lot of that is the secular trend of critical care is just getting better over time. And that may be in the way that we deliver and we organize our care. And that has been driven essentially by data. And so I think that data has a big part to play, and I think we saw that in our last talk. Abby was just showing us, it's quite humbling watching that. I'm just trying to get at least that in one single center in Toronto up and running, and she just showed it across the world. So very humbling to watch that talk. But the data that you're getting that's driving and helping you to deliver care. And so the data opportunities in acute brain injury, just to highlight a few here, at least within my institution, are numerous. And again, there's nothing really new other than possibly much more sophisticated imaging and the omics data. But it's the way that we can now create and synthesize and aggregate this data together. And now as we're coming out of our silos and working much more across the trajectory of care, so we're trying to work more with our partners in the rehab world, and we're trying to then synthesize that data together. And that just gives us a much more wealthy database when we actually look at our acute care and look at their long-term trajectory. And the data structure as well is also very important to think about. We're going to talk a lot more about the neurophysiological data in this talk, but as you go down, the increased shading here shows the increasing data volume as you go down. And it's been proposed that if we are much smarter in the way that we can process that data together, it really helps us to build a couple of models, diagnostic models, prognostic, and also predictive. And these are iterative, right? So your prognostic models can really help inform your predictive or your prediction analytics moving forward. And so how come all this data from our monitoring, our technology in our neuro ICU, what is it helping us with? So here is, I love this paper by Giza, and senior author was Geert Mayfreud from Intensive Care Medicine in 2015. And they did this very novel concept at looking at ICP dose. So basically along your x-axis, you have the ICP value, and on the y-axis, you're looking at the time spent at that ICP value. And they were looking at this, what they call pressure time burden of intracranial hypertension. And then what they found was the yellow line here is when you cross over from a a good outcome into that worse outcome. And as you can see, as you go along the x-axis, higher degrees of ICP values you can't tolerate for as long. But this idea of just a threshold-based one single value as opposed to more of this ICP dose, I think we're going much more to more dynamic measures than just a one-off. They had an ICP greater than 20. I went and treated it. More about the area under the curve. Another thing that we've found from the data is possibly this one-size-fits-all does not apply. And I think that's in most of our ICU patients, but more so in brain injury. And even our recent Brain Trauma Foundation guidelines has been updated to reflect this. Now, maybe a little bit simplistic, but we can see already there's an individualization of your targets for your age here, for your systolic blood pressure. Going back to that Giza paper, they also did another analysis within that paper, which I think is fascinating, looking at your ability to tolerate intracranial hypertension. And there's 3 different lines here. The first one is, if we take, I know the new value is 22 for ICP, but I think it's a bit of an arbitrary number. I think there's a spectrum, but if we could go back to the old value of 20, and this is all comers here, we could see that they could tolerate about 30 minutes before they cross over from that relatively good outcome to a bad neurological outcome. But then if we then use our data to try and create subgroups, and we actually look at patients that had cerebral autoregulation intact, so that's pressure reactivity, we can find that they tolerated up to 150 minutes before they passed from that good to bad outcome. And what's more concerning is when we look at the patients who didn't have autoregulation intact, so they were dysautoregulating. That usually means a right shift in your curve, and usually a very small plateau where we're regulating our cerebral blood flow. But we find that they could actually, when autoregulation was disrupted, only tolerate about 15 minutes. And so that is helping us to prognosticate, at least here. And the Brain Trauma Foundation guidelines have been updated to reflect this, where again we can see that we're starting to think about patients' autoregulatory status as a way to individualize care. And this is an analogy that a lot of us use, is that the data that we get from neuromonitoring is helping us to see things that maybe the eye can't detect. So a bit like flying a plane in the middle of a night with none of these other gauges that we're used to, like pressure, velocity, air pressure, and speed. And so really we're finding that with this new monitoring data, although we haven't been able to improve outcomes yet, although I think there's some good studies on the way, like Boost 3 from Laurie Schutter and colleagues, looking at whether we can actually detect these neurophysiological insults, treat them, and hopefully improve outcomes. What we can do at the moment is we've seen that we're detecting brain insults that otherwise we wouldn't have been able to see standing at the end of the bed. And this is actually is much earlier work from Professor Menon and Professor Vespa, where they found that the conventional measures of intracranial pressure and cerebral perfusion pressure, which were completely fine, when they started to look a little deeper and they were looking at brain tissue oxygenation and markers of metabolic stress, like using cerebral microdialysis, they could actually detect these episodes of brain crises. So we seem to be moving away from more of what we currently know, which is the standard monitoring, to more what we think we might need to know to help us provide care. And that really involves going above and beyond just a pressure indices to thinking about flow, oxygenation, and metabolism. So really what's underneath that superficial level. And using this approach, the technology and the data we're getting from, we're moving much more to an integrative neurophysiological approach. This is helping us to understand the fundamental mechanisms of secondary brain injury and helping us to possibly identify new therapeutic targets. And I really like this was, I've adapted it from Professor Mauro Oddo, where when we think about how the data from neuromonitoring has really changed how we care for our patients, the top line there I'm just going to take for example is our sub-Iraq patients, where by using physiological data, we have now really changed from the classic Triple H therapy. We've learned that actually we're doing harm to them, and at least in our institution, we only use induced hypertension. If we go down one line and look at actually sub-Iraqs and in traumatic brain injury, and we look at brain tissue oxygenation, we've really gone away from approach of hyperoxia to controlled oxygenation and more lung protective ventilation. And I've highlighted a few other ways that the data from technology in ICU has helped us to adapt the way we care for patients. There is a few challenges as we go forward, as always, and some of the barriers to thinking about this data science and acute brain injury is that we're all using very different monitors in our ICU, and the standards for how we collect data and how often we collect those data points is very different between centers. There's also not really a good answer to how we deal with artifacts and missing data. And I just wanted to highlight this paper from Claude Hempel and colleagues, where they actually looked at the optimal resolution of time series data. So I don't know about you, but in our unit, yep, we have a bedside monitor that's collecting data, or at least is capturing data every 1 to 3 seconds, but we actually unfortunately dump that data after 24 hours, so we're losing all of that data. Our nurses still, though, they write hourly data points on a paper sheet. Yes, we're still there, we're still on paper in my hospital. And when I want to go back and look at a patient, I only have that hourly data point. And actually, if you ask some of our nurses what that hourly data point represents, it means very different things. Sometimes they'll tell me, well, I put what I think was the best or the worst, or what it was at that point, at that hour, or I kind of averaged what I thought was the best marker of what they did in the past hour. So we don't really know the validity of that data. And actually in this paper, he very nicely showed that actually when we use hourly data and compare it to time series data that's collected continuously every second, we miss significant brain insult events. So when we try to think about this intersection between technology and the data we get from it and how we look at this data, this kind of data highway, brings into a new problem, right? We're finding that the way that we visualize and interpret all this data is problematic. There's so many streams of data now coming at me from a neuro ICU perspective, and to the point where as an intensivist, as a staff intensivist, I sometimes struggle with all the data points. I think there's some great studies showing that we look about 150 data points at times. And in neuro ICU, we have the general ICU monitors and pumps and infusions, but we also have in brain injured patients all these additional third-party monitors. And if you can imagine, I struggle at times to think about where they've come from, where they're going, and then to synchronize all these different variables, what my residents are feeling. And there's that great paper from Miller, which was, what was it, the magic number 7, which is to say that we as human beings, our cognitive ability is we struggle past 7 variables to interconnect those and find relationships with them. And so if we're truly to understand this whole integrative neurophysiology approach, we need to really look better at this end part here of the data integration and visualization perspective. And I think that's really been understudied, the way that we can actually look at our data and integrate it and then allow us to analyze. Because a lot of the papers that we talk about are all they're after the event. We go offline and we go and analyze the data and we find these relationships. But I want to know how I can find those relationships at the bedside. And so we've been doing a lot of work in this area with cognitive engineers and human factors to understand how we interact with all our data. Because sometimes I might have 4 to 5 monitors at the bedside. Continuous EEG monitor, a brain tissue oxygenation, an ICP monitor, which might be a Codman, that I might be able to feed back into my native monitor at the bedside with all of my systemic parameters. There's a lot of data floating around my patients in neuro ICU. And then this is what I currently look at within my ICU, and I'm ashamed to say that, so the sweep rate on this is about 6.5 seconds, and so it refreshes after that point, and it does go to a central monitor, but we dump all of our data after 24 hours. So we're losing out on the opportunity to collect data like this, and we've been really working within our center to really accumulate more of a neurophysiological platform, which is why I found it so humbling when I'm trying in just one institution, and Dr. Beam was talking about her worldwide data. And so this is where are we going? I don't think we're quite there yet, but I'm a bit of a Trekkie fan, and I grew up with this, and so I kind of see that we're going that way, where you can see here there's a panel of predictive analytics helping us possibly at the bedside to understand these relationships. And some of the opportunities when we move forward. And so this is some of the exciting data from the TRACK TBI. I know that after this session we have Professor Menon who's going to be talking about the center TBI data, so I've really tried to remove most of that from my talk, but I just wanted to show you this exciting data from the North American TRACK TBI data, where they're looking at the multidimensionality of traumatic brain injury. And they were using what's called a topological data analysis technique, which is a machine learning analysis. And they actually, as a pilot study, in 3 centers, looked at just under 600 patients. And they were trying to capture all this multidimensional data for traumatic brain injury, because we know the limitations of current data for brain injury. The kind of clinical classification of mild, moderate, severe, probably it doesn't quite cut it. And I'm just going to take you through some of how they displayed that data. So here we have a 2D analysis, and this is a representation of individual patients with 2 functional outcomes here, post-traumatic stress and Glasgow Coma scale score. And then here's the actual data where they actually started to layer the multi-dimensional data. And so each patient here, if we can just see the drawing lines between each of their data points as they move through each of these different layers. And then what they were able to do was they color-coded patients that's basically like subphenotypes grouped together. And that allowed them to create nodes of patients that through multidimensional data appear very similar. So very much like Dr. Calfee's work in the respiratory critical care arena, this is us trying to look at subphenotypes in brain-injured patients. And here is, as they amassed this data to look at syndromic, try to get a better syndrome-based map for traumatic brain injury as opposed to that very basic clinical mild, moderate, and severe. It's a little bit complicated, but I've just highlighted here. So here is mild traumatic brain injury, and the blue means negative, no. So they had no findings on their CT, no findings on their MR, but the red means yes, they were positive. But actually, they found this subgroup out on this far side of the node here, where they actually had high rates of post-traumatic stress. That now they could actually identify when they come in with even, and classically, when someone had a negative CT, we would think that they were really minor on the scale of long-term bad outcomes. And they also find they actually mapped this to poorer Glasgow outcome score as well. So, I think I just explained all that, but just to say, so the multidimensional analysis of brain injury, this is really what this pilot study was trying to do here, and they've been really trying to map individual patients to these syndromic spaces here. And I think they showed very interesting data, maybe not in our population. I don't tend to look after mild traumatic brain injury, but there's nothing to say that this same syndromic map can't be mapped to severe brain injury. So in conclusion, I mean, whether you work in a dedicated neurocritical care unit or a general critical care, we all care for very vulnerable brains. And sometimes it can be very hard to detect when they are deteriorating, especially in a comatose patient. But the data that we've been getting from our neuromonitoring technologies is really helping us to understand these secondary brain injury mechanisms and how treatments might be helping. And that data really is evolving at a fast pace. And I think we're seeing more and more that individualized, tailored approach at the bedside as we use monitoring technology. And then on top of that, we're always going to have to incorporate an integrative analytics platform as well when we start to get more and more of this monitoring at the bedside. So I'd like to say thanks very much, and I'll end it there. Thank you.